Good afternoon and welcome to today's webinar. My name is Grace McManus and I'll be your tech support for the duration of the webinar along with my colleague Maya Dean Polyak, who you'll see typing in the chat. This training was developed under the Substance Abuse and Mental Health Services Administration's Prevention Technology Transfer Center Task Order and is for training use only. And now that I've covered all the housekeeping items, I'm going to turn it over to Jay Yarbrough, the Training and Technical Assistance Coordinator of the Central East PTTC.
Thank you so much, Grace. Again, my name is Jay Yarbrough, and I am the Training and TA Coordinator with the Central East PTTC. And welcome everyone once again to this webinar titled Peer Support and Community Reentry for Prisoners with Opioid Use Disorders. Just a little background information on the PTTC. The network is made up of 13 centers. That includes the addiction and mental health PTTC as well, which make up the 10 regional centers, the network coordinator office, the National American Indian and Alaska Native Center, and the National Hispanic and Latino Center. The Central East region covers Health and Human Services Region 3, as you can see the map there, which oversees Delaware, DC, Maryland, Pennsylvania, Virginia, and West Virginia. And what we do at the Central East PTTC, so we accelerate the adoption of evidence-based and promising treatment and recovery-oriented practices and services, strengthen the behavioral health awareness, knowledge, and skills of the healthcare and prevention workforce that address the needs of people with behavioral health disorders, foster regional and national alliances among culturally diverse practitioners, researchers, policymakers, funders, and the recovery community, ensure the availability and delivery of publicly available free of charge behavioral health training and technical assistance to healthcare and prevention professionals. Here's a quick shot of our mission at the PTTC. And one of our specialty areas is engaging and collaborating with primary care providers for substance use prevention. And eligibility for services through the Central East PTTC, as you can see here, is behavioral health and healthcare providers, consumers, families, state and local public health systems, and other stakeholders. And here are a list of our focus areas at the Central East PTTC: opioid and harm reduction strategies, suicide prevention, youth vaping, tobacco, youth alcohol and suicide, health equity and elimination of disparities and trauma, workforce leadership development, data-informed decision-making, and environmental strategies. And here's a short list of some upcoming webinars that you will see at the end as well. Other resources within Region 3 would be the Central East Addiction TTC and the Central East Mental Health TTC. Both happen to be housed at the Danya Institute as well as Central East PTTC. And one of our pillars at the Central East PTTC is a people's first philosophy, and that is that words have power and language matters. And with that, I want to welcome you guys once again to today's webinar. I'm going to hand it over to our presenter, Derek Kreager.
Great. Thank you, Jay, and good afternoon, everyone. Nice to virtually meet you. Get to learn a little bit about you. It looks like Jose wins the prize for the furthest distance in the Philippines. So before I get started, I first want to thank Deborah, the Danya Institute, and the PTTC for inviting me to discuss some of my ongoing work. Specifically, that focused on relapse prevention for justice-involved individuals with opioid use disorders, which I'm going to talk about today. So this is a great opportunity for me to share my research with such a broad audience and practitioners as well, which I really appreciate. So before I begin my presentation, here's just a little bit more about me and my biography. I received my bachelor's degree in psychology from the United States Military Academy in 1993 and a PhD in sociology at the University of Washington in 2006. And then I moved on to Penn State, where I've been in the Department of Sociology and Criminology for the past 15 years. My research is primarily focused on social networks and health risk behaviors, such as substance use and delinquency among adolescents and young adults. But for the past 6 years, I've also been working with the Pennsylvania Department of Corrections to understand the social networks and health of individuals incarcerated within the state prison system. I and my team have been able to interview hundreds of incarcerated men and women and measure their peer and family relationships and then connect these to health and treatment outcomes. And as part of that research, we quickly noticed that there are very few resources available for incarcerated individuals as they reenter their communities, and which is particularly problematic for those with substance use disorders and requiring continuity of care and social support to maintain their recovery. And that knowledge sparked the intervention evaluation that I'm going to be discussing today. So that's a little bit about me. It would also be great if I could understand a little bit more about you, which obviously isn't easy given this one-way mirror style of presentation, for example, I'm in my basement. But if you wouldn't mind, please answering this quick poll about your profession and your exposure to justice-involved individuals in your work. And this might also help me focus on particular aspects during my presentation. Let's give you a minute or two to fill that out. All right, great. It looks like we've got a really broad group of folks. Nobody representing my profession of academia, which is good. I'm talking to somebody different than I normally talk to. Okay, this is really helpful. And a lot of people who have worked in the criminal justice system or with justice-involved individuals through their practice, which is also great. And so there's obviously already going to be a store of knowledge out there that I'm talking to. Okay, very helpful. And also, please feel free to ask questions as the presentation goes on, especially clarification questions. I will try to answer as I go, but then as Grace mentioned, we'll have some time at the end for some remaining questions about the presentation. So what I first hope to convey today are the risks facing reentrants with opioid use disorders, and it sounds like a lot of you already know, are well aware of those risks. I'm then going to define and describe the potential benefits of an intervention that connects peer-certified recovery specialists to this vulnerable population. Finally, I'm going to discuss the challenges facing this kind of intervention and some preliminary results from a pilot study that I'm conducting. As my own research and experience is centered on Pennsylvania, many of the example statistics and programs that I will discuss focus on that state, but I also attempt to place these in a national context wherever possible. A useful place for us to start is to discuss the large number of individuals who are currently leaving state and federal correctional institutions every year. After 30 years of an era of hyper-incarceration, where the United States has led the world in its incarceration rate, we are entering a period where rates of imprisonment are leveling off and ever more individuals are being released to their communities, a process that has only been accelerated under COVID-19 and policies of decarceration. In Pennsylvania alone, over 20,000 state prisoners are released to their communities in an average year. And this number would be far greater if you include those with shorter sentences housed in county jails. The increase in the number of individuals released from correctional settings has coincided with the ongoing opioid crisis, which has hit rural Appalachian communities particularly hard. According to recent CDC statistics, Pennsylvania is behind only West Virginia and Ohio in its opioid overdose rates, and is currently at a rate of over 44 annual deaths per 100,000 residents. And this doesn't include the bump which will be associated with COVID-19. And as you can see from the chart on this slide, overdose deaths increased rapidly after 2010. This is primarily due to the shift in the availability of prescription opioids, which became less available, such as OxyContin, and the introduction of far more lethal fentanyl into legal markets. Important for this presentation, justice-involved individuals are at much higher risks of opioid use than the general population. This is not surprising, given the connections between addiction and criminal behavior, particularly property crimes that financially support illegal drug use, and that drug use, especially with harder drugs, remains a crime. So one 2018 study found that 30% of the then incarcerated individuals could be diagnosed with an opioid use disorder, a rate that climbed after 2010 and is likely significantly higher today. And that is also true in Pennsylvania, again in Appalachian State, has a lot of rural population, and that population has been also associated with prescription opioid. The opioid crisis facing incarcerated populations has not gone unnoticed by prison administrations. In the past, there were far fewer resources dedicated to prison-based substance use treatment. And these typically consisted only of therapeutic communities, which are peer-based treatment programs and cognitive behavioral therapy. Within the past decade, however, administrators have attempted to meet the demands of the opioid crisis by expanding services both within and outside of prison. In Pennsylvania, for example, the Department of Corrections now permits medication-assisted treatment, primarily Suboxone, in all of its facilities. It has also expanded health benefits for reentrants. It's designed opioid-specific therapeutic communities, and it's piloted other promising drug therapies, including methadone maintenance. It has also partnered with researchers such as myself and community health providers to make sure that any new policies are evidence-based and properly evaluated to ensure their efficacy. All of these are very positive steps that would have been much more difficult under the previous era, when prison authorities were far more focused on the maintenance and security of an ever-growing incarcerated population over efforts of rehabilitation and reduction of recidivism. Even though positive steps have been made in prison-based treatment for substance use disorders, a missing link remains the continuity of care upon prison release. The existing parole system prioritizes deterrence and surveillance to prevent recidivism and reincarceration. But it's not difficult to see how this system is not a very good fit for those with substance use disorders and histories of addiction. As shown in this graph, the risk of overdose death, which is primarily from opioids, is incredibly high immediately following prison release, and then declines substantially over time. And I and my team found a similar pattern in a social network study we conducted of incarcerated individuals released from a prison therapeutic community. In that longitudinal study of over 200 incarcerated men, we found that over 70% relapsed within the first month post-release, even though many were not detected by the criminal justice system or reincarcerated or rearrested. Indeed, rates were even higher among those with prior opioid use or who were residing in community correction centers or halfway houses. The current parole system doesn't adequately address this high-risk period, and in fact exacerbates it because reentrants don't feel they can trust their parole agents, as these agents are primarily charged with reporting violations rather than approaching addiction through a disease lens. What's needed then is an intervention outside of parole aimed at establishing continuity of care in the weeks immediately surrounding prison release. Continuity of care has been found particularly important for opioid use, and interventions in this area have focused on overdoses and emergency room admissions, such that individuals who overdose are the targets for inpatient treatment prior to leaving the hospital, maintaining their recovery. And in many ways, these high-risk individuals leaving prison are akin to those leaving emergency rooms, and that both require interventions to not return to the revolving doors of their addiction. Within Pennsylvania, the Certified Recovery Specialist Program is a particularly attractive means of supporting reentrants with OUD. Also called peer recovery coaches, CRSs in Pennsylvania are credentialed individuals with lived experience of addiction. CRSs have to successfully complete a 54-hour training course, and I believe that's actually going to increase in this coming year to be over 70 hours. And they have to have passed board-certified examination. In addition, many CRSs have experience in the criminal justice system. Again, this connection between addiction and substance use disorders and involvement in the criminal justice system. And this can be particularly useful for reaching out and gaining trust of previously incarcerated clients. Such is the case for the CRSs that are taking part in the pilot study that I'll mention on the next slide. The primary role of CRSs is to serve as informal sources of social support for clients in recovery, to include assisting clients with needs related to treatment resources, transportation, family support, employment services, or just talking to individuals during periods of crisis. All of which are critical for previously incarcerated individuals who may be new to a community and have weak or broken bonds with friends and family members. Moreover, due to their shared experience of addiction, CRSs can be trusted and always available advocates for their clients during the important and risky. So Deborah asks, how is lived experiences defined? Any substance or opioid only? For CRSs in Pennsylvania, the CRSs have to be in recovery themselves. It doesn't depend on the substance. It just means that they have experience with addiction and are currently in recovery for at least a 2-year period. Our peers also formally incarcerated. This is not the requirement for a CRS, for the Certified Recovery Specialist Program in Pennsylvania, but they do typically, CRSs who search online for employment will mention that they have prior incarceration experience or criminal justice involvement, because it actually does increase their match to a particular set of clients that have needs related to the criminal justice system. Any other questions? I think there might be one, but I'll return to it. So to add CRSs to the prison release process, we designed a pilot study that connects CRSs with individuals incarcerated in Pennsylvania state prisons. For this study, we've partnered with the Race Community Recovery Program, which is centered in Harrisburg, Pennsylvania, and the Bureau of Community Corrections within the Pennsylvania Department of Corrections. So the organizing principle of this collaboration is to have CRSs meet with reentrants before they exit prison to create a recovery plan, understand what community-based treatment resources reentrants will require, and learn about the reentrants' family situations and needs. And then our role at Penn State is to evaluate the program and take the lessons we learn to refine it and bring it to a larger scale. So this collaboration is very, and none of these agencies have really, I've worked with the Department of Corrections before, but not with the Bureau of Community Corrections. So all of these relationships are new, and part of this collaboration, part of this study is to make those, to make sure that we can meet those requirements of collaboration and be on the same page to make this kind of a project work, which is obviously critical to making it at any larger scale. So the question, how is being in recovery defined for the CRSs? And do you have to be in a program? That's a good question. I actually don't know the answer to that. I do know that the requirements for the certification are that they be in recovery themselves, but I'm not actually sure how that's defined. I think if you go to the Pennsylvania Certification Board, they actually list the official requirements, and so actually Chris, who's got a last name very similar to my own, who just said that she is a CRS, or maybe he, might be able to answer that. Liz also asks, it's great to hear criminal justice system involvement is considered a plus for being hired. We found a transitions clinic network that having community health workers with a personal history of incarceration as a core part of the team is critical in providing support to people returning home from incarceration. Yeah, and I totally agree. And actually one of the, and this is sort of a side comment, but one of the historical problems with reentry for criminal justice populations is that actually associating with those who have a history of incarceration or criminal involvement is a parole violation in itself. I think this is starting to be relaxed within many states, but as you can see, and just anecdotally, that's going to be problematic for these kinds of programs. And I think it's missing a critical opportunity where folks who have experience and want to give back to those who are in the criminal justice system can be the best means of ensuring recovery. And that's kind of what the basis of this program is all about. That's the philosophy that we're operating under. And so Diane mentions there that for recovery in the PRS program in Nevada, that it has to be 2 years without relapse, which it could also be true in Pennsylvania. Okay, move on. I'll continue to answer questions as they come up. So here's a little bit more about the RACE project. And again, it's operated primarily out of Harrisburg in Pennsylvania, but you'll recognize this kind of community nonprofit, and probably many of you on this webinar work or have worked in similar kinds of organizations. It employs CRSs, and as you can see, it also provides additional services such as transitional housing, group therapy, or even employment service to those individuals in recovery. And RACE CRSs can then connect reentering individuals with both the RACE services that are provided at their centers, as well as other services in the community that it doesn't cover, such as medication-assisted treatment. And as many communities across the state and across the United States have organizations similar to RACE, it's hoped that the results from this pilot study can be scaled up to connect CRSs to previously incarcerated individuals across larger geographic regions. And so coincidentally, the office that we work with in Harrisburg, it's in downtown Harrisburg, the RACE facility is actually right across the street from the Dauphin County Community Corrections halfway house. So many of our participants will reside in that halfway house and then walk across the street and meet with RACE. And then we will make that a more formal process where they can connect to them prior to even leaving inpatient treatment. I'll get back to some of the questions here. Okay, all right. Okay, yes, so I think there's some good information that the folks have who are currently peer recovery specialists or CRSs as they're called in Pennsylvania. Again, there's a lot of language here depending on the state and levels of certification. But I think that's one of the things that's starting to change, which I think is a positive direction, is some of this is becoming a little bit more standardized, at least in Pennsylvania. So we can work with a lot of different organizations and sort of have an idea of the fidelity of the treatment, so that we can create programs and understand their benefits and challenges and apply those across multiple regions. So that's one of the things we're hoping to do with this kind of a program, is be able to start on a smaller scale, but then be able to take what we learn and apply it in different treatment settings and hopefully see similar results. Okay. So the participants in our pilot study, which we've just gone into the field, and I'll explain a little bit more about that. We are focusing on currently incarcerated participants in the Pennsylvania State Drug Treatment Program, which used to be called the State Intermediate Punishment Program, or SIP. So this is a 2-year voluntary intermediate punishment program for current nonviolent incarcerated individuals who are diagnosed with substance use disorders. Once identified as eligible, based on their intake information, individuals in the program all progress through the same treatment while they're incarcerated, and then they move into inpatient treatment. So they begin in a therapeutic community while they're in prison. They then progress to an inpatient treatment facility, and then they move to outpatient treatment for 6 months prior to a 12-month community reentry program. And then once they're done with that, this flat 2-year sentence, they are not under parole supervision, and their sentence is completed. So there's obviously a benefit to this, where there's people who successfully complete the treatment can then progress to not being under supervision, and then maintain their recovery. And that's kind of what we're hoping with this program, the CRS program, is to make sure that reentry process maintains their recovery and keeps them out of reincarceration or relapse. And so one of the questions that comes up about this drug treatment program while incarcerated is, what happens if you don't progress through the system? And it's similar to a drug court in that if you fail, if you relapse, for example, at certain points, it's really up to the administrators of the program whether or not you'll roll back or stay in a certain phase for a longer period of time, or in extreme cases, if there's not movement towards recovery, the program could be revoked and you serve your original sentence. But this is really an attempt to try to divert nonviolent drug offenders who are incarcerated into a treatment program that then moves them out of prison at a quicker rate and keeps them on a path towards recovery. So for our particular intervention, CRSs are assigned during the phase 2 period, and then the idea is to have the CRS meet with the participants immediately upon the transition from inpatient treatment when they're under 24-hour supervision to outpatient treatment when they're really back on the street. And depending on their plans, their recovery plans, their reentry plans, they may be living with a family member, or they may be living with in a community correction setting in a halfway house. But that period of exiting inpatient treatment would be the period of greatest vulnerability, as reentrants would be returning to situations where drugs are more readily available. They can get connected to their pre-existing networks, and there's going to be a lot more triggering events to possibly to trigger relapse. We're currently focused on those participants re-entering their communities in 2 Pennsylvania counties, Dauphin and York, which are in the Harrisburg region, and both of which are covered by the RACE organization. And so our eventual aim is for this pilot study is to recruit approximately 30 individuals, follow them during this intervention, and then interview them afterwards to understand their subjective perceptions of their recovery and the role of the CRSs. You know, obviously some folks will drop out of this program, and we hope to maintain connections with them so that we can understand why that might be. And then we'll also, and as I'll talk about maybe on the next slide, we'll also be interviewing their family caregivers who are providing informal social support, and that's also connected to this intervention. So as I mentioned a little bit earlier, the intervention itself is connecting CRSs with re-entering clients prior to their release from inpatient care and providing them informal support both to the clients and to their primary caregivers. So it's that second part that's also fairly novel with our intervention. And some people, I think, in the chat have mentioned that they are certified family recovery specialists, which is sort of hitting on this idea. But we are also having the CRS connect with a primary caregiver prior to the client's release. And so this part of the intervention is aimed at better understanding the challenges that the client faces in their family context, as well as to educate the family on addiction treatment and overdose prevention. So really trying to bring a family member into the social support network. And that even includes providing the family member 2 naloxone doses and instruction on how to use those should their loved one experience an overdose. And once the client is released from inpatient care, the CRSs attempt to meet with them within the first 24 hours of them exiting inpatient treatment, and then bring them to RACE to introduce them to the services that are available there. The CRSs then help the clients achieve their recovery plan, and that's going to be established in that first meeting at RACE, and then check up on them periodically and remain available to respond to any crises or periods of need. And although our pilot study as currently administered is only focused on that first month of post-release, because that's the period of highest relapse risk, the participants are encouraged to remain with the CRSs throughout their recovery period. So if it's working, you don't want to intervene in that beneficial relationship. So that's part of this, is to see, and then we'll check up later just to see how long the individuals stayed with the CRS and how effective that has been for outcomes such as staying in recovery. And so although the CRSs are not really part of the correctional system, right? They're not a parole, a member of parole. They are part of a community recovery program. So they're not mandated to report parole violations, which then helps them build trust with clients. But we have talked to the CRSs, and the CRSs really want to encourage clients to report any relapses to parole, and then the CRS peer would advocate for them as part of any subsequent sanction determination. So not being part of parole doesn't mean that the CRS is going to try to hide these kinds of violations from parole. And understanding that deterrence and the parole does have a function, but trying to be an advocate for the client at all times. And also just to build trust. And that would all be communicated to not violate that trust. Let me look at some questions. Okay, so some good resources on CFRSs, the Certified Family Recovery Specialists, and some potential programs to reach out to families. And so that actually I'll follow up later. I think that's useful. Because it is certainly what we've found is that the continuity of care for reentering individuals is a topic that there's a lot of emphasis on right now. People are very concentrated on this idea of how do we support recovery and deterrence for assistance for people who are reentering their communities, but they haven't necessarily been able to link with the ideas of social networks, social capital, and families and recovery capital. And I think that's what programs like this could be particularly useful for. So that's one of the reasons that we're trying to get involved in this kind of a program and hopefully move it along a pace. Okay. So what we're going to do at Penn State is then evaluate the intervention. So we're not involved at all in the intervention. We help recruit individuals, do a preliminary assessment just to understand more about the background of participants, and also to connect the CRS, help connect the CRS to the clients, and so basically acting as an intermediary in this process. But our primary focus is to then follow up with the participants, the CRSs, and the prison administration or the correctional administration to get their perceptions of this program. You know, what's working, what didn't work, what are the primary mechanisms that might be able to improve recovery. And then the idea is to take the lessons learned from those from that data and refine the program and try to bring it to scale so that we can actually get some more causal estimates, do a randomized controlled trial of a larger number of participants to really be able to see how much of this is actually affecting and improving recovery. So that's the long-term goal. But right now, we're still in the process of recruitment, and I'll talk a little bit about some of the preliminary things we've seen. And we've only have 4 people right now. We just started last month. And then we just finished our first post-release interview of a participant. And so I can talk a little bit about, but obviously draw strong conclusions given the small sample size. We're also going to be getting some post-release, after 6 months and a year, understanding of their rearrest, understanding administrative data, essentially, to see if there are any differences that we can observe in this population compared to the average person who's released from this prison program. We're not going to, again, be able to draw strong conclusions from that, but we will be able to see if they're bad. And then also, one of the things we want to evaluate is, because of the CRS programs and the organizations that run, the nonprofits that run CRS programs, they often have different kinds of policies. We also want to make sure we understand the process and really see how closely the CRSs adhere to their own policies and look at the treatment fidelity to make sure that we can take lessons learned from that and say these are the sort of best practices that appear to be most effective from the participant's perspective as related to CRSs and reentry. So we were actually just ready to enter the field when COVID hit last spring. Literally the week that we were going to start this program, COVID shut down any sort of research activities in Pennsylvania. And so obviously we were delayed. Visitation was suspended in any correctional settings. And still today, and I'm sure you can see this in the news, the correctional administrations are very much focused on trying to reduce infection in their facilities. And so research has been suspended, and we're hoping and we're starting to see some relaxation of that so we can actually start to proceed. And the reason that we've been able to get some people into this program, which has only been in the last month, is that we shifted all of our recruitment activities into a virtual format. So luckily some of the inpatient, or actually all of the inpatient treatment facilities that we're dealing with have a virtual conferencing capacity, and so we're able to talk to participants or eligible participants virtually and do the consent process and explain the program and have them enter the program without meeting them in person, which it took a little while to get that approved by our university, but now that we have that, it's always going to be available to us, which is good. It will improve even after COVID. It will improve our capacity to be able to reach institutions or inpatient treatment facilities across the state. So our goal remains to finish the pilot data collection this summer, which would be almost exactly 1 year after our planned completion date. So even though we're just beginning to implement this intervention, there are some clear challenges that have already emerged, and they're not surprising given the population that we're working with. It's become immediately apparent that engaging family caregivers is a challenging and ever-evolving task. The participants' family structures are often very complex, and these relationships are further complicated by histories of addiction, abuse, and broken trust, and the period of incarceration itself weakens some ties to family members and to those who would typically be involved in the recovery and have social capital for these individuals. And additionally, reentrants may believe that there's family support waiting for them after they get released, when no such support actually exists. So they have reentry plans, but those reentry plans just deteriorate or fall apart once they actually get on the street. And what happens then for those individuals is they enter into the halfway house. They move back to the community corrections programs. And often those situations may have more drug availability, more risk exposure for individuals than even being incarcerated or their prior pre-incarceration environment. And so those are all challenges that we have to deal with. But of course, they're also all challenges that the CRS is meant to meet. And that's why the CRS we think is important for this population. Of course, it complicates communication, planning, and the provision of services. But I think one of the keys to success is to make sure that the CRSs are communicating as much as possible with the clients as early as possible prior to their release. So none of this information is a surprise, and that the CRS can actually sort of figure out the landscape of where the reentrants are going to be moving to, and either try to facilitate or at least let the participant, the client, know what information they are able to gather. So in other words, again, it's this continuity of care idea. The CRS can do this sort of information, knows what sorts of challenges exist for these kinds of individuals, and then be able to foreshadow and maybe deal with some of these complications before the participants actually come back into the community. And at least have some available resources that the person can rely on. And family instability has also been connected to housing instability and changing living arrangements that obviously also pushes the participants, the clients, back into these community correction centers. And again, the CRS can help with this housing, but it takes time, and often the clients don't necessarily have that kind of time. So identifying these issues as far upstream as possible is pretty critical, I think. And finally, COVID and its collateral consequences has been particularly problematic for this vulnerable population, which is likely to also suffer from underlying health conditions, already have employment challenges, and be easily triggered when introduced to completely new environments, which many of them are re-entering. And so part of what we've redesigned our interviews to be able to capture some of those experiences of COVID and the complications, the complexities of COVID for recovery and reentry for this population. So hopefully that's another set of lessons that we might be able to take from this project is what does COVID and this kind of a pandemic mean? And we already know that it's increasing rates of both substance use and overdose. But what does it mean for treatment, and what does it mean for recovery? And we're already starting to learn some of the tools in the community of how we can deal with this, but getting this sort of firsthand knowledge from a re-entering population, I think will be valuable. Okay. But even though challenges exist, there are already some clear benefits that are coming through, even with only 4 participants. The initial indications are that the CRSs really are able to be trusted peers who are available to support reentrants during their time of immense need. So we have 4 participants who 4 eligible participants who we approached, and all of them agreed to participate. And so that actually wasn't what we were expecting. We thought that some individuals might not see the value in this or think they can do it alone. But in fact, everyone we've approached so far sees that this is something that can be helpful, and at least something to try, to not necessarily just dismiss offhand. And all of the 4 individuals who have re-entered their communities have met with their CRS. So again, these are positive signs that we hope to get some more valuable information going forward. And anecdotally, Our participants were also universally excited about meeting a CRS and working with race. And I think just that perception of thinking about the future in a way that's positive can also help in the recovery process. At least there's something to hold on to if a lot of the communications with family members or plans that are already being developed don't necessarily turn. So again, I think that's another positive development that hopefully we'll also see in the post-release interviews. And should the pilot study show promise, another benefit of this intervention is that the CRS training can actually be offered in prison settings, which can then provide reentrants with strong employment opportunities and help in their own recovery. And so as a criminologist, I know that there's a desire of previously incarcerated individuals to give back to their communities. And one of the strongest motivations for recovery and assistance is to be able to help others who may be justice involved. And then also this is a very cost-effective, all we're really paying for is the salary of the CRS. And then again, hopefully what we can do is scale this up to a larger population. I just looked at the time and noticed that I'm running a little bit over, so I'm gonna try to be speedy. I only have a couple slides left. So as I mentioned, what we're really hoping to do with this pilot study is figure out what are the pieces of this intervention that are the most critical for it to work effectively. And that's what those subjective interviews are about, get those perceptions, and then tailor the intervention to make sure that the most important parts are always included, and then try to take those lessons learned and scale it up to more kinds of agencies, to more kinds of communities, and eventually to others who are substance users or have substance use histories that don't involve just opioids. Okay, and then obviously to get that kind of an intervention working, we also want to get external funding, and hopefully we'll target the National Institute of Justice as we think that it will be interested in this kind. So that actually concludes my presentation, but I do want to mention here, which I think is another piece of this, is that it takes a lot of people to do this kind of thing. We have to have 3 different agencies involved, and we have to have researchers, practitioners, and treatment providers all part of this intervention. And I think that's also one of the obstacles that prevents some of this kind of work, is because you have to facilitate these interagency ties between organizations that don't necessarily have a history of working together. I think we're in a good time to do that. I think the prison administrations are looking for evidence-based policies, and those policies and those providers are becoming more available in communities across states. So I think it's opportune, but it also does take a lot of work. So I think that's all I had. Yep, that's it. So I'm going to open it up to questions. I know we don't have much time, but I did want to leave a couple minutes in case there are questions. Let me look here. So thank you, Pamela. I think you're right. I think this kind of an intervention using recovery coaches is very flexible and is very able to be used. I particularly am excited about the idea of providing this kind of training to those who are currently incarcerated. And so we're working with the Penn State and other universities within Pennsylvania that provide prison education programs to try to increase the opportunities for this kind of training. The certification exam can't be taken while incarcerated, but the training itself can. And so you can get those 54-hour credits, or soon to be 72, I believe. Those can all happen, and it's a good use of someone's time while they're incarcerated to prepare themselves for reentry, to learn more about addiction, and to feel like they can be useful to communities and provide a sort of avenue for employment. So I'm excited about that, and there hasn't been enough conversation, I don't think, about that. And I'm really trying to facilitate that, because there are within the Penn State university systems, so we have branch or Commonwealth campuses across the state, and a lot of them do provide this kind of training. And so I think offering that within the state prison system, it could be very valuable. And obviously it would be less available for those in county jail just because the turnover is so fast. You wouldn't have an opportunity to really to get to know students or have students be able to complete the required coursework. So, okay. Yeah, and so I know conversations are currently happening about the provision of these courses, and we are working, and we have it's called a Restorative Justice Initiative in the Pennsylvania, the University Park, Penn State campus that works with the Department of Corrections on educational programming, mostly focused on course credits for a bachelor's degree, but also trying to offer these kinds of more technical training to help with employment for incarcerated individuals. So that is something we certainly want to improve and strengthen over time.